Thank you very much. After two such sophisticated clinicians who are experts in this field, I will be speaking about my modest animal studies actually. I will be focusing more on neuroinflammation and the point that we are at today and some new findings for the future. In general, for mood disorders, some pathologies are more difficult than others. For depression, at the synaptic interval, if NEAT and SERT are below a certain threshold, then we consider depression. So the mechanisms which control this are being blocked in current treatments in order to normalize. However, in 1/3 of the cases, we have a severe resistance, and sometimes these drugs even appear on media in press and make us think whether these drugs are effective or not. Since 1950s, we moved from medicines which focused on a single monoamine level to very different drugs. Looking at bipolar treatment, there's a more challenging situation because lithium is the only anti-manic medicine, and as a monovalent cation, this molecule is the one that you get the best response. It has totally intracellular effect through receptors and particularly through the secondary systems. It reduces the level of IP3 and it turns into D-phosphate and then into IP1 and then into inositol. And the level of IP3 is being reduced. This is the action mechanism of the medicine. Including bipolar treatment for depression, schizophrenia, and all psychiatric diseases, we have a severe resistance at the foundation actually, and we have neuroplasticity and inflammation hypothesis frequently there. Both at the molecular and cellular level and also at the structural level, there are some changes. We need to consider them all together. Neurotrophic factors, reduction, intracellular mechanisms, mTOR, up and downstream mechanisms of mTOR, neuronal atrophies, synaptic plasticity, and inflammatory responses of the neurons and glia take us to 3G, glu, GABA, and glycine. One is excitator, the other is inhibitor, and glycine looks like an inhibitor, neurotransmitter, but it has a special place actually, a special role. It has an effect, it can connect to the receptors and therefore plays an important role. In order to control these balances, these 3G neurotransmitters are important and we are focusing on them. And for 3G, looking at the current situation, regarding the glutamatergic system, there is a neuronal atrophy. There's a decrease in apical dendrites and dendritic spine density is reduced. And regarding the GABAergic system, we have a neuronal hypertrophy, particularly in the amygdala. Hypertrophy is reported. There are synaptic plasticity increasing as well as dendritic processes. Both the prefrontal cortex and amygdala mechanisms are controlled, and an ideal antipsychotic, antidepressant, and mood stabilizer should be able to increase dendritic spine density and also suppress pro-inflammatory cytokines and prostaglandins, to prevent the suppression of them. So there's a need for a new drug medicine mechanism. For long, we have focused on sickness behavior. In the acute phase, there's an increase in fever, lower locomotor activity, and pro-inflammatory cytokines are increasing. Microglia, pathological microglia, is activated in this process. Patients on interferon treatment, we observe in these patients, also in animal studies, when we give IL, beta, TNF, alpha, LPS, and to these animals, when we give anti-inflammatory drugs to these animals, the depression-like symptoms are decreasing. So there's a correlation and association. If you have sickness behavior and inflammation, and if you can end this, then it won't turn into depression. But if it becomes chronic and continues to increase, then you have depression. The anti-inflammatory cytokine production is parallel to this, particularly in treatment-resistant groups. Anti-inflammatory cytokines are significantly reduced, and pro-inflammatory cytokines, both in the periphery and microglial activation, they are increasing significantly. If there is clinical resistance by the patient, then in the long term, this process will increase. Anti-inflammatory cytokine production will be reduced, while pro-inflammatory cytokines will increase. Some recent studies show that in inflammatory diseases, depression prevalence is very high. It has been underlined once again. Moving from this point, inflammation, neuroplasticity, and mental diseases. Between these, there has been found to be a strong association. But there are so many inflammation markers and pro-inflammatory cytokines in the periphery were studied in many of the studies, but these didn't give us much of an outcome or didn't help us make an early diagnosis in the clinic. So can we find another marker which will give us some earlier data, which are being activated in the earliest phase? Macrophages and microglia cells on the surfaces of these cells. My slides keep changing without me doing it, actually. Okay, toll-like receptors. As you know, they are present in the membranes of macrophages and microglia cells, and they were activated by severe pathogens, as we knew, but we have learned that they are activated by stress. After TLR is activated, then interleukin 6 and TNF-alpha is released, and within the cell, node-like receptors are activated, and when they are activated, and inflammation-specific component, inflammasome protein, is being activated. And this protein activates caspase-1 and strong pro-inflammatory cytokines, interleukin beta and interleukin 18. These pro-inflammatory cytokines are being released. So what is inflammasome? It's a protein, actually, node-like receptor protein, and procaspase-1, and there's an ASC bridge binding them. The activation of this receptor increases interleukin-1 beta and 18 release. So pro-inflammatory cytokines, before they increase, inflammasome should be activated. There are three types of inflammasomes: LR LRRP1 specific to neuron, LRRP2 specific to astrocyte, and LRRP3 specific to microglia. And the 1 and 3, NLRP1 and 3 have been studied recently. Their activation may sometimes be caused by some sterile activities, level of glucose or cholesterol, for example. Other than this, bacteria and viruses, many pathogen activators are also there. But most importantly, stress can activate this mechanism with the same power as pathogens or others. There is a case control study in this field actually. There is a clear finding here that particularly NLRP3 activation and caspase-1 expression is increasing. And there are protein increases in the tissue as shown in this study as well. So NLRP1 and caspase-1 increase is evidenced in this study. Let me point another thing here. This is a BH4 is a cofactor for monoamine synthesis and a target of inflammation. For some time we have ignored nitric oxide synthase. It is also a cofactor of nitric oxide synthase. Why am I talking about this? Let me remind you that azote monoxide nitric oxide has 3 different nitric oxide enzymes that are inducing it and activating it. And there is an electron exchange here, and it can turn into a free radical and may lead to stokine production. And nitric oxide is also determines the level of glutamate over the ROS. So to sum up, what I'm trying to say is that if nitric oxide is at a certain level, then in the periphery there are some positive events, but it's also a part of plasticity. But if its level is increasing at pathological levels, then it can turn into free radicals and it can become a part of the pro-inflammatory process. So I would like to speak about the recent research that we have carried out. As you know, L-arginine is a precursor for nitric oxide release, and L-arginine, not all of it is used for nitric oxide. Through argine carboxynate, it is transformed into agmatin. Agmatin has a very important function actually, and it is the only known nitric oxide synthesizer. So we have agmatin. Within the neuron, it is released, and imidazolin receptors and NMDA receptors and many other receptors are being affected. It is diffused very rapidly and has a very broad action mechanism. And this molecule protects the neuron and has many central functions which have been identified and published recently. I won't be getting into the details. Inflammation, oxidative stress, and neurodegeneration perspective is important for us, particularly for mental diseases. It has a modulatory role. In this context, looking from the perspective of antidepressant effect, we see there are preclinical and clinical studies, lots of them. Some of them are experimental studies which have been participated by us. Let me tell you about the most recent one here. In an experimental animal model, we modeled depression and tested the effectiveness of agmatin and to investigate the hypothesis of inflammatin. and the two models have met all of our criteria for validity and quality. Augmentin is a novel transmitter with antidepressant activity. There were two previous studies, one of them with lipopolysaccharide and one of them with tumor necrosis factor alpha. These were the depression models that were created. We first produced chronic stress and tested the effectiveness of augmentin. It was a preliminary study actually. What was exciting and a new finding here was that the levels of NLRP3 compared to all other pro-inflammatory cytokines and caspase-1, actually in parallel to them, there was an increase in LRP3 both at the hippocampus and prefrontal cortex. So if you can increase the level of augmentin, it may have a very important effect of protecting the patient. And in parallel, looking at the pro-inflammatory and anti-inflammatory cytokines, we have supporting findings there. Then we used a chronic model, chronic unpredicted stress model in rats. We created a depression model, and then we wanted to confirm it with another model, maternal separation, separating the infants from the mother in the first 2 hours after birth, and then restrained stress and social isolation models were used for confirmation purposes. Here our purpose was to check the pro-inflammatory, anti-inflammatory cytokine balance, and we used chronic stressants, and we had anhedonia syndromes, and pro-inflammatory cytokines increase was confirmed. Cross preference test is used actually as a very important factor, and in parallel with other behavioral tests, we have a severe level of anhedonia, and both in the hippocampus and prefrontal context, the PCR, Western blot, and IHC were checked, and the GFAP and IBA1 levels were controlled. Just to go very quickly over this, the depression-like behaviors were observed. Immobility, duration of immobility was checked, and in the prefrontal cortex, NLRP levels were increasing. It was interesting. Not just NLRP3, the microglial one, the neuronal one, NLRP3 was also increasing. Particularly, it was suppressed by augmentin in the prefrontal cortex, and in parallel, the selective NOS inhibitors were checked. In the hippocampus, you can see with this model, neuronal and microglial NLRP levels are increasing significantly, but they were suppressed by augmentin treatment, and protein expression levels were also checked. Caspase-1, pro-caspase-1 levels, both at the hippocampus and prefrontal cortex, they were suppressed. And the mRNA levels in prefrontal cortex, you can see for IL-1B, 18 and 16, augmentin was successful in suppressing them. Also in the hippocampus, they were suppressed. So, moving from this, whether there are any structural changes or not. Hippocampal IBA1 immunostaining was carried out, and we saw that augmentin had a very important role of protection. So as a conclusion, augmentin is a potent antidepressant molecule, and in terms of innate immune response, it has some protective effects. So the dosage that you use is effective, is important, and at the right dose, it can give us a new treatment mode. So at the current level, we can see that the 3G is ahead of the monoamines. And so in this mechanism, GABA and glycine hypothesis and HPA activation here, as you know, before the pro-inflammatory stockings, the inflammasome pathway should be investigated, neuroplasticity, oxidative stress, and behavioral changes that manifest the pathology should be checked. I would like to thank my team who made this study possible, our contributors, and I would like to thank you also for your attention. And I would like